Right, hello everybody. Officially hello now, we've started talking properly. So I'm really pleased to introduce today Dr. George Moncrieff, and we're obviously going to be talking about the use of steroids, in particular with the use or in reference to moderate to severe eczema. But I think George has had an illustrious career, I think that's the right word to use, in the dermatology field. And George, it'd be great if we could ask you just to give a quick background of all the different organisations and people that you have you've worked with.
Well, that's very kind, Katrina. I'm not sure I remotely deserve such a title, but I won't bore you with all the minor things I've been doing. But I was a GP for over 30 years in Bicester, and I retired from my NHS practice about 4 years ago. More recently, I have been the clinical lead for a community dermatology service in South Birmingham, looking after about 1 million patients and receiving referrals virtually mainly with skin problems in that area. When I was a GP, I ran a community dermatology service for about 20 years, and all my local GPs, about 80 GPs in total, sent almost all their skin problems my way, so I could see them and decide whether we needed to involve secondary care, that's hospital. I was the curriculum guardian for dermatology for the Royal College of GPs for some years, and I was a postgraduate examiner in the Diploma of Dermatology Cardiff for many years. And more recently, I was the chair of the Dermatology Council for England, an unusual organisation, that sort of an umbrella organisation that tries to bring together the voice of patients, the pharmaceutical industry, nurses, GPs, consultants, anybody who has a relevant interest in dermatology, and trying to produce a unified opinion and voice on matters affecting them in the world of dermatology. And I left that post about 2 years ago. But now I'm fairly retired, which I quite enjoy.
I think quite a lot of us are retired almost. It feels like we're almost retired at the moment because we're all stuck in.
Well, I'm about to start as a vaccinator, so I'll be doing quite a bit of that. Oh. And I'm still continuing as an advisor for the pilot service that we set up in Birmingham. Oh. And I do occasional GP locums and things.
Well, okay, so today we're going to talk about steroids. And I think I'm very aware that steroids, or the use or the type of steroids, etc., can be a sensitive topic for both patients and for the medical profession. So, and there's sort of a couple of disclaimers, I suppose, that I'd like to say to start off with. Is first of all, is that at Talk Health we totally endorse the correct use of steroids for the management of moderate to severe eczema. That is absolutely not in question at all. And also, and I'm sure George will also say that George is talking purely from his own personal perspective of, treating people with AD eczema over the years. And this isn't, he's not speaking on behalf of any professional body or anything like that. So I just wanted to make that kind of clear. So now we've kind of got over, that sounds like the grown-up stuff, is let's get on with what we're really here to talk about. And so what George wants to do is talk about how how we can treat our skin, what's the best way to treat it, what alternatives there are out there, which for some people will not be aware of. But to do that, he feels it's really important that we have a really detailed look at the epidermis, or actually have a real look at the skin, how it works, and so that we can have a background to understand how the skin works, and then how we can start treating. And it's important to understand that before we start looking at the options how to treat it. After we've done that, and I think George has put together a short slideshow, and after that we'll talk about general how to self-manage, how to try to lessen the flares, etc., that many people do experience. And we're absolutely stressed, we all totally understand how devastating and difficult that can be on people's lifestyles. And then, as I said, practical things, and then we'll go on to our usual Q&A session at the end. We have decided that because there is a lot for us to discuss, that this session is going to be roughly an hour long. So questions will come at the end, but please feel free to start posting your questions as we go along. We will try and obviously answer as many questions as we possibly can, but we may not be able to cover everything. So George, let me let me pass it over to you to start talking about our skin.
Thank you very much indeed. Thank you, Christina. Yeah, I need to be absolutely clear. The views I'm sharing with you today are very definitely my own, and I don't want you for a moment to imagine that those organizations I have been affiliated with in the past would take any responsibility whatsoever for the views I'm sharing with you. They're my personal views that I have reached in my own personal way. And they're based on how I have approached managing my own patients over the years, and it's worked very well for me, I think, most of the time anyway. I confess that actually I have put together some slides, as you suggested to me, and it's slightly longer than I had suggested, so I might be spending a bit longer with my slides, but I think they're there to support what I'm trying to explain and will hopefully make the information I'm trying to pass and share with you more easy to understand. Let me say, though, before I go any further, that I am not wanting you to take away remotely from what I have to say today that I don't want us to use steroids. Of course I use steroids, topical steroids. I use them all the time in my practice. I couldn't imagine trying to practice in dermatology without them. There are some inflammatory conditions, skin conditions, for which we have no other suitable alternatives at all. And yet they do work. They don't smell, they don't stain. And if they're used properly, they can be remarkably effective, life-changing, and broadly speaking, safe. And furthermore, I have to say, I would share my colleagues' frustration when I'm asked to see a patient with a steroid-responsive rash, and I see their tube of steroid that they were prescribed and it hasn't been touched or has barely been touched. And they're coming again because their skin hasn't got better, and we have this impasse that they don't want to use it, or they're too frightened to use it, or they've been advised not to use it, or they use it too sparingly. And yet they have a condition that we could have sorted out so easily had they only adhered to the advice that they were given. But that's not to say that there aren't problems with topical steroids, considerable problems. And I think, if I'm really honest with you, I think the profession has been too blinkered over the years to some of those problems. And we haven't listened to our patients who are telling us that they have problems or that they have concerns. And I think for us just to go on banging on saying, you've got to use them, without stopping and thinking, is that the only option? Is doing nobody a service. So with that in mind, what I'd like to do is really go into some detail about the structure of the skin, how the skin works, and therefore why I have concerns about topical steroids. Concerns that don't stop me from using them for a moment. Please don't take out from this that I don't want you to use topical steroids if you're prescribed them, but there are ways to use them effectively, ways to use them safely, and we need to get that balance right. And that's really what I'd like to try and reach, that area of understanding. So with that in mind, can I share my screen and bring up the slide deck that I was hoping we'd be able to use? So there we go. I'll press share. And I think we're now sharing, is that right?
Yep.
Good. So I called it the truth about topical steroids. It's the truth as I see it. It may not be the absolute truth, but it's my truth. I think my thoughts about atopic eczema start, and the word atopic eczema, the word atopic actually comes from the Greek, meaning a without, topic, a place. And in 1923, two guys called Coker and Cook first recognized that asthma, eczema, and hay fever seemed to occur more commonly in individuals or families than could be accounted for by chance. They linked them together, but they had no idea what it was all about. Allergy wasn't a concept, and they didn't understand the immune system. So with no place to classify it, it didn't fit into cancer or trauma or infection. In the textbooks, they had no place for it, so they called it atopic. And eczema is just, again, a bit more Greek, ek meaning out of. So, for example, an ectopic pregnancy is out of place. But here you have eczema, which means outboil. You get little bubbles deep in the skin that bubble up to the surface. And if they can't get out, they're contained. But normally they come to the surface, split the skin, and ooze out some fluid. So we're just using a bit of Greek to describe what we're seeing. But the thing that concerns me is this graph, that in really just almost just 2 generations, 3 generations perhaps, we have gone from an incredibly low prevalence of atopic eczema to today's epidemic levels. So there's something that we're doing in the last 70 years or so, 74 years, that is driving that. That's far too fast for genetics to be the explanation. And how does eczema start? Well, there are various thoughts, and this is a big, complicated slide. I'm sorry to make it so complicated. But we have definitely got an abnormal immune system there on the left in blue, an immune system in individuals who are genetically prone that is behaving in an abnormal way. And maybe a vulnerability that's also genetic that makes them more likely to have an immune trigger. Over on the right there, you've got skin barrier failure. The skin barrier fails to protect the body, and things can get in, and that can be genetically driven or environmentally aggravated, that allow things to get into the body through the skin and trigger this abnormal immune response, and then inflammation. And then once the skin's become inflamed, it's itchy, you can't help but scratch it. Scratching causes more damage and more inflammation, and you get a vicious cycle set up. So it's a complicated interplay between genetic vulnerability and then environmental and actually essentially lifestyle factors. The two are sort of interlinked, but I want to focus here now on skin barrier failure. Because when you get eczema, I think that opens the door to the immune system misbehaving in someone who is prone to atopic disease. And I think it is eczema that opens the door to food allergies, and then on to asthma, and then long-term into hay fever. There's a definite link we've known about now for almost 100 years. But I think it is eczema that opens the door to this whole process, and it's sometimes called the atopic march. But let's just go now into a bit of anatomy of the skin. So what is the actual anatomy? Well, the skin is essentially made up of two layers. Deeper, you have the dermis, deep down, and it's in the dermis, you've got the bulbs where the hair follicles grow from. You've got the sebaceous glands that produce sebum, that's grease that goes around the hair follicle to stop water getting around it and causing a folliculitis. But also that sebum comes out onto the surface and acts as a surface barrier, very useful. You've got the little coiled gland there on the left, which is producing sweat, that's right down deep. You've got the nerve fibers, you've got blood vessels. That's the main structure of the skin, is deep down in the dermis. The top layer of the skin is called the epidermis, and it rests on top of the dermis. And it's actually made up of about 4 or 5 very discrete layers. The very top layer of the epidermis is called the stratum corneum, and you have what are called corneocytes. And it's the stratum corneum, that's where the skin barrier is, that very, very top layer of the epidermis. And that is all we need, that we depend on to protect us from this hostile world that our bodies live in. It's the barrier between us and the outside world. It stops water getting in. As water getting out, I mean, it stops bacteria and viruses and allergens penetrating the skin and triggering abnormal immune responses, which are going to be occurring a bit down in the skin, a bit deeper down. However, this top layer of the skin is unbelievably delicate and vulnerable. On the eyelid, it's only about 30 or 40 micrometers thick. 1,000 micrometers is a millimeter. So that stratum corneum in these areas is half as thick as a piece of paper. And in infants and older people, even thinner. It is extremely thin. But I'm going to share with you just how remarkably, astonishingly sophisticated it is. It's incredible, absolutely incredible, the stratum corneum. My heart sinks when I hear doctors saying the stratum corneum is made up of dead cells waiting to fall off. Yes, they're cells that are moving to the surface and falling off in a remarkably coordinated fashion. And yes, they haven't got a nucleus. But I asked those same doctors, do you think of the red blood cells that go around your circulation as dead cells? Have you got dead cells going around your bloodstream? No, you haven't. They haven't got a nucleus. They're terminal. They're not going to live for more than 3 months or so, the red cells. But they're no more dead, and they're incredibly sophisticated, and you depend on those red blood cells in the same way as we depend on the stratum corneum. Just beneath the stratum corneum, the skin barrier, you have cells that are forming granules within the cell structure, the cytoplasm. And this is where it does get a bit complicated, but bear with me, please. There are 2 types of granules. There are the keratohyalin granules and the lamella granules. The keratohyalin granules are producing essentially two main things. They're producing very strong protein rods or filaments. And these actually are within the cytoplasm of the cell, the sort of material of the cell itself. It acts inside the cell, rather like steel rods in some reinforced concrete. The other thing that the keratohyalin granules produce is a protein, a very, very large protein called initially profilagrin, but that rapidly breaks down to filagrin. And that name, filagrin, comes from just joining up filament aggregating protein. So it's a filament aggregating protein. It aggregates these filaments and it forms them into a lattice. So they're all stacked up one on top of another. When that gets to a critical size, that collapses on itself, very much like an ironing board being put away. It causes the cell to, it just stretches itself out. It's a long stretch. And that changes the shape of the cell from being rather more box-like, cuboidal, to becoming very, very flattened with enormous overlap between the neighbors. So here's a sort of schematic drawing of the skin showing, going up towards the surface. And I've put there a very thin blue arrow of water loss. There's very little water escaping. Those green things are bacteria that would love to get into your skin, but they can't because the cells are overlapping beautifully and pushed up against each other and forming an effective barrier. Let's look at this in a bit more detail. These corneocytes have been stretched so much that they are only themselves about 30 micrometers long. So they're almost as long individually as the full depth of the stratum corneum, but they're only about, actually less than a micrometer deep. So they're flattened like little plates, one on top of another, forming this fantastic overlap, enormous overlap with a huge surface area for bonds to tie them to their neighbors, tight bridges that hold them together. The lamellar granules produce an oily material made up of cholesterol, ceramides, triglycerides, all sorts of different fats, and these ooze out from those cells and fill the spaces between those cells, very much like the mortar in the brick wall. So they're forming a seal between the corneocytes in the stratum corneum. And that's called a lamellar envelope. It forms itself into a bilayer. These fatty materials have polar ends that don't mind being in contact with water, and non-polar ends that need to be away from water. So they orientate themselves so their long non-polar tails are pointing away from the water environment, and the polar ends are pointing out. So it forms itself naturally into a bilayer. And this confers some flexibility into the skin as well. It makes the cells move over each other more comfortably. And most importantly, it seals the space between the cells. This is produced by that granular activity. Then what happens is the profilagrin, having changed the shape of the cell, can now be broken down. And that's broken down into a whole load of very, very small molecules. And these molecules are what are called hygroscopic. They draw moisture to them. So they're natural moisturizing factors, or NMF. And they draw moisture up from the very deep layers of the skin into that cell and then hold it in that cell. The cell is beautifully hydrated and therefore pushed up tight against its neighbors, pumped up full of this water that's being held in the skin. The skin doesn't feel dry. It's got a lovely appearance. But notice all these small molecules, the breakdown products of filagrin, are acids, amino acids, lactic acid. There are others like brodylene carboxylic acid and urocanic acid, but they're all acids. Now these acids drop the pH with a measure of acidity. When it's neutral, it's 7. If it's 10 times more acidic, it's 6. If it's 10 times more than that, i.e. 100 times more than 7, it's 5. Going the other way, if you reduce the acidity by 10-fold, you go from 7 to 8. So it's what's called a log to 10 scale. Now, the pH at the junction of the stratum corneum, the very top layer of the skin, and the next layer down is neutral. But by the time you get to the surface, and you've traveled half the distance of a piece of paper, in some areas of the body just 30 or 40 micrometers, you've dropped the pH 100-fold. You've dropped it down to 5. Now that's called the acid mantle, and the body isn't just doing that by chance. It's doing it for very, very good reasons. There are enzymes, chemicals. These are chemicals that digest protein. There are enzymes called proteases that digest those bonds that hold the skin cells together. But their activity is controlled by that pH. If it's at 5, it's got very little activity. But by the time it gets up to 6 or 7, you've doubled the activity of those proteases. And they'll be breaking those bonds that are holding the skin cells together. It's called the acid mantle. And this is made up of those breakdown products of the acids and the lactic acids and things, but also the free fatty acids, which are the breakdown products of triglycerides. So those triglycerides are getting broken down by healthy, normal bacteria. But interestingly, also sweat is acidic. And as we get older, we make less sweat. Don't stop making sweat, but we make less, and so do infants make less sweat. And of course, when you wash that off, you're losing the advantage of that acid contribution to the acid mantle. This acid environment also favors the adhesion of your healthy microbiome, the bacteria you want on your skin, the ones that will stop the bad bacteria getting there. And it's antiseptic to the bad bacteria. So this acid mantle is really, really important. When it's controlled, the bonds, the cornea desmosomes, the big strong bonds, which actually they penetrate through that cell membrane and link into those tonofilaments. Once the tonofilaments have changed the shape of the cell, they then link up with these cornea desmosomes that penetrate through the cell and join up onto those tonofilaments, giving fantastic adhesion between the cells. You have a wonderful, healthy skin barrier. Minimal controlled water loss. Bacteria, viruses, allergens just don't get in. And so even if you've got a genetic tendency to eczema, which actually, interestingly, you may have inherited because our ancestors, those ancestors who had a slightly weaker skin barrier might have been able to vaccinate themselves against smallpox, or cats rather, and therefore be protected against smallpox. That's one of the theories why the gene has persisted for so many generations and centuries. But today's environment is reaping complete damage on this skin, and then allowing things to get through, and then if someone genetically prone, triggering very abnormal pathways deeper in the skin, causing eczema. Which brings me on to my real concern, which is detergents. Detergents are a very, very modern phenomenon. People never used to wash, and today we have this fetish of washing with detergents all the time. Detergents are designed to degrease the skin. They'll rip out that lipid lamellar envelope. They'll rip off that sweat. They'll rip off that surface sebum from the sebaceous glands. Instead, you could wash with an emollient. And an emollient, not only is that pH buffered to maintain the surface pH at the slightly acidic level it should be, but they also re-grease the skin rather than degrease it. So detergents are horrible alkaline agents, and they neutralize that acid mantle, causing untold damage. I tell my patients, your eczema is never going to settle until you stop detergents. I absolutely just say all soaps, shower gels, shampoos, bubble bath should never go near the skin. They're very, very abnormal. Our skin never evolved remotely to cope with today's detergent barrage. The synthets, the synthetic detergents, are slightly less alkaline and slightly less damaging, but most soaps and shampoos are harsh and damaging. We've got a problem though, because the coronavirus has a lipid lamellar bienvelope as well, and the spike proteins are attached to that lipid lamellar bienvelope. So yeah, in order to kill the virus, one of the best ways of doing that is to use soap. So nowadays I am washing my hands with soap thoroughly, but then I wash with an emollient to wash that soap off, to recover the pH, to re-grease my skin, and dry them carefully and put some more emollient on. But I have to say, when I see somebody with eczema, atopic eczema, that's not nicely controlled, I will sit back and say, tell me, how do you wash? And they often look askance and say, what are you on about? And I say, what do you have a shower? Do you have a bath? How long are you in the shower for? How long in the bath for? How hot is the water? How are you washing? What detergents are you using? What shower gel are you using? If you wash your hair, are you really letting that shampoo rinse all over your skin? Are you standing in a broth of detergent? Are you surprised your skin hasn't a chance of recovering? It's never going to get better with this modern, very abnormal behavior. You'll end up with damaged skin, huge amount of water escaping. Inflammation, once it becomes inflamed, switches off that granular activity. You stop making the keratohyalin granules. You stop making filaggrin. You stop making that lipid lamellar bienvelope. And so the skin doesn't stand a chance of trying to recover itself. You've got dehydrated corneocytes. They've got no natural moisturizing factors because you haven't made any filaggrin. So you can't draw moisture into them. They split and crack away from their neighbors. They haven't changed shape properly. They haven't got that huge overlap. The lipid lamellar envelope is defective. You're not oozing out that material. You haven't got the granules to ooze out. So the cement's missing. The protease activity, therefore, is accelerated. These enzymes are no longer being inhibited by the acid environment. It's become alkaline. And the pH of somebody with eczema is abnormally high all over, not just on the areas where you've got eczema. The whole skin pH is raised. So the protease activity is going to be greater. Your microbiome is going to be messed up. You've got bad bacteria. You're just ready for everything to start going wrong all over again. You've got disastrous damaged skin. And once you've got inflammation, you set up the pathways that cause more inflammation. So more bacteria get in, the whole thing becomes a complete vicious cycle. You've got increased water loss, the skin becomes dry, it's itchy, you scratch it, and the vicious cycle is really driving now. So what about topical steroids? Well, back to this slide here, the vicious cycle is definitely catastrophically aggravated by itch and infections. And topical steroids will block that inflammation brilliantly, and they'll break that cycle. So they're one of the most effective agents we have at just splitting at that vicious cycle open and controlling that inflammation. So when you've got a flare, and a lot of inflammation is the dominant problem, topical steroids are the right treatment. But topical steroids are even older than me. They're even older than paracetamol. They've been around now for 68 years. These two great guys were the first people to crush up some hydrocortisone acetate and put it into an ointment and see what happened when they put that on the skin. And it opened the world for modern dermatology, transformed our management of skin diseases that otherwise would just be destroying lives. So yeah, compound F was a fabulous discovery back in 1952. And they really do work. And I said right at the beginning, they don't smell, they don't stain. And normally, unless you're putting onto very inflamed skin, they don't sting. And more often than not, problems arise because people aren't using them adequately or properly. However, they are really only there to deal with the flare. They're not designed to prevent flares. They shouldn't be used for flare prevention. And if all you're doing is managing flares, you're basically a fireman, basically. You're putting the fire out, but leaving the embers to come back up again. You're not thinking about that skin barrier. You're not thinking about your lifestyle. You will have another flare. And the average number of flares that somebody with moderate atopic dermatitis has per year is about 9 to 11 per year. Each of those lasting up to half a month. So in other words, half your life is spent with a flare. And of course, immediately after a flare, the skin is still abnormal, hasn't got back to normal. So you could almost justify using flare treatment 365 days a year. It's not ideal. So when the skin has flared and it's really inflamed, inflammation is a dominant problem, and steroids are probably one of the best treatments we have for controlling that flare initially. They are the right treatment in that situation, and that's how I use them. They're not used for longer term. Most of the problems arise when people do use them for longer term use and beyond a couple of weeks. They're not licensed for more than 2 weeks for eczema. But steroids damage the skin barrier. These are the problems that I want to draw to your attention. They raise the surface pH. They neutralize that acid mantle. That means that you're not able to maintain your normal skin microbiome. You've lost the antiseptic properties. You've activated your proteases, the enzymes, these chemicals that digest the bonds. They degranulate the granular cell layer. That's the last thing you want. You need those granules. They're critical for producing that skin barrier. Steroids break down protein. They turn protein into glucose. That's why we don't like using steroids in people with diabetes, for example. It raises blood glucose levels. It converts your protein in your muscles and things into glucose. Or similarly, those corneodesmosomes, those bonds that hold the skin cells together, those are proteins. They break down proteins. And if you've been on steroids for more than about 9 months continuously, you will have halved the number of cell layers in the stratum corneum. It's thinner. A thinner barrier is weaker. But of course, you get eczema where the barrier is at its weakest. Eyelids, face, front to the elbows, back to the knees. Those are the areas that are most vulnerable. These are thin skin areas. You look at the skin, for example, on the sole of the foot, it's about 600 micrometers, not 30. And on the body, it's around about 100 to 200. You're less likely to get eczema there than you are on the really thin skin areas. But if you start peeling it down and making it half the thickness, well, things are going to get worse. They're small molecules. They're less than 500 kilodaltons, which is a relatively small molecule, which means they are absorbed down into the deeper layers of the skin. In the dermis, that area that I showed you, the deeper layer, you've got lots of a protein called collagen. And collagen is the main supporting protein for the skin. It supports the blood vessels. It supports the skin. And when that's removed, the skin starts to look paper thin and you can see through it. You bruise more easily because the blood vessels aren't supported. And you get stretch marks. I've seen stretch marks within a fortnight of starting a potent topical steroid. And in little babies who've got a very high body surface area to weight ratio, there's much more skin to them per cell in their body than there is in an adult. If you put a potent steroid onto their skin, it'll get absorbed through that very thin skin, and it can suppress their normal steroid levels and their normal steroid production and have major effects there. When you want to know how potent a topical steroid is, you put it on the skin and you see how much it causes, how much vasoconstriction, that's narrowing of the blood vessels it causes. It makes the skin go white. And you measure how intense that is and how long it lasts. And that tells you whether it's mild or moderate, which is 10 times stronger, or potent, which is 50 times stronger than a mild one, or super potent, which is about 200 times stronger than a mild one. So how much vasoconstriction is how we measure its strength. It causes the blood vessels in the dermis to contract, and so the skin looks whiter. But some individuals experience intolerable rebound. When the steroid effect wears off, they get intolerable rebound. The skin looks red and painful. And they discover that the only thing that gives them any relief from that is to put more topical steroid in, and they end up with steroid addiction syndrome. And when they withdraw it, they get terrible rebound problems called steroid withdrawal syndrome. And that can be really miserable for them. It doesn't happen to everybody by any means. In fact, it's a very small number of people, but I think it's under-recognized. And I think some people end up having to use steroids because their skin is so uncomfortable when they don't, and they just wish they'd never started. Steroids are very powerful anti-inflammatory agents. That's what they're meant to do. They're brilliant for that reason. But inflammation is our body's way of dealing with things. If inflammation is a problem, fabulous. But when you depend on that inflammation to contain something like a fungal infection, a bit of athlete's foot fungus that's got onto your skin, if you inadvertently put even a weak steroid on that, you compromise the body's ability to keep that fungus at bay, you damage the skin barrier, the fungus grows down deeper, and you then get a modified fungal infection, hard to diagnose, hard to treat. The suppression that steroids produce is not targeted, it's global. It knocks out the entire immune system. Both what's called the innate and the adaptive are compromised pretty significantly by topical steroids. They're powerful at knocking out inflammation and immunity. Going back to some of the vascular problems, the blood vessels, rosacea is very definitely seriously aggravated by topical steroids. I've seen a mother who, more than once, I've seen mothers who have been looking after their children's eczema. wash their hands after putting some steroid on their eczema. There's a tiny residue on their hand, and then they go to bed. That residue is all it needs if it gets into contact with their face to cause rosacea. There's a condition called perioral dermatitis, which is incredibly common, and I have never seen that in someone who hasn't been using topical steroids. Topical steroids are brilliant at calming the inflammation, so initially it seems to help, but then makes it massively worse, and so they go up to a stronger steroid, which again controls the inflammation and makes it look a bit better before it gets even worse. So those two conditions would be greatly improved. Perioral dermatitis, I think, would disappear if we didn't have steroids. Rosacea would still be there, but we're making it worse. And I've even seen rosacea and perioral dermatitis aggravated by the very small residue that comes from using an inhaled steroid for hay fever or asthma. Very rarely people have become allergic to the steroid molecule. You can imagine how complicated and difficult that is if you're allergic to hydrocortisone or bepivate. It has been described, and it does happen. Well, we had no alternatives until the end of the last century, but now we do. We have got alternatives. And I call these secondary care's secret. We have agents called topical immune modulators. And I need to stress I have got no shares in the companies that make these or any other interest in them. But these are wonderful drugs. They're safe. I put that in inverted commas. Nothing is completely safe, but these are, in my book, massively safer than steroids. They're effective. One of them is as effective as bepivate, as effective as a potent topical steroid. And they're licensed for long-term use, and they are intended to go on thin skin areas, like the eyelids. We have two. We've got protopic ointment, we've got Elidel. I won't go into them in any great detail. But what they do is they restore the skin barrier, unlike steroids, and they modulate the immune system. They don't just knock out the immune system, they modulate it. So they switch it from being the abnormal pathways that you see in atopic dermatitis back to the non-atopic pathways. So you're not aggravating and driving that inflammatory process. They regranulate the stratum granulosa. Unlike topical steroids, which raise the pH and make it alkaline, they maintain that surface pH. And their target immune modulation means you're not getting suppression of other problems. And they are absolutely, they're sometimes called topical calcineurin inhibitors. So I call them TCIs. Topical calcineurin is TCI. TCS is topical corticosteroid or topical steroid. And they're ideal for the thin skin areas, i.e. the areas where you get eczema. More than that, they are licensed for long-term use. They're licensed for flare prevention. So they're ideal for that purpose. In the UK, they're licensed from 2. However, I've been using them now for 20 years nearly. 16 years I've been using them, 17 years I've been using them. And our experience has shown us over those years that this class of drug is remarkably safe and effective. Very few drugs have a license down to 2. When they were first licensed in the world, back in 2002 or 2003, no, it was 2001, and it was 2004 we had a nice guideline. In 2001, I had been doing a little bit of work with a company that make pimecrolimus, which is a very, very large molecule, by the way. It doesn't penetrate the skin. We had safety data going down to 3 months of age. And in New Zealand, they're licensed from 3 months of age. So when I was asked to see Ludo, who is the son of some very close friends of my son, who had very bad eczema, although he was actually under 2, and this is off license, I'm not endorsing this as a practice for everybody, but I was confident that the right treatment for him was not steroids, but Protopic. And I put him onto Protopic at the lower strength, which is licensed for children, and within a couple of weeks, it melted away. And we've kept it at bay completely with a maintenance dose of Protopic, which is just using it twice a week, a trivial dose. Just perhaps Wednesday night and Sunday night, very small amounts or even less as it gets better. So topical steroids, yep, I do use them. If you're going to use them and you need to use the emollients, which of course you need to use emollients, I'd say put the emollient on first, everywhere where you ever had whole skin. The whole skin's abnormal in eczema, not just the abnormal areas. And then after about 30 minutes, ideally, just put the steroid ointment on the affected areas where you need to treat it. I start potent to try and get complete control and then drop down the frequency is my personal way of using it, but I might use different strengths in different parts of the body, and patients need written instructions to help them with that. I only ever prescribe steroids as ointments because ointments have a very low water content. So therefore they don't need preservatives. And because you may need them again and again, I don't want to cause a sensitivity to a preservative. Ointments stay where you put them. Ointments actually work better. They have a natural enhancing skin barrier effect. They occlude the skin to prevent water loss. But they actually have they're slightly more potent gram per gram than creams. And there's no point, I think, ever in using a topical steroid more than once a day. So putting an ointment, which is sticky and less cosmetically pleasant, on when you're then going to sleep, I don't see as a big issue. So I urge my patients to use ointments last thing at night when they go to bed. And you need to use enough for it to work. And so patients need to be told how much to use. You know, there's one intelligent thing in the world of medicine. It's the only one I can think of, really. The one intelligent thing is that all tubes, however big or small they are, all come with a 5mm nozzle. And so when you squeeze an ointment out from a tube, covering the tip of your finger, of an index finger in an adult, that's half a gram. So a 30-gram tube will have 60 fingertip units. And each fingertip unit can cover an area of skin the size of 2 palms. So that's the quantity you should be using. The skin should feel slightly sticky and tacky, not completely covering it, but sticky and tacky afterwards. And then I think don't stop your steroid suddenly, particularly if you've been on a potent or super potent one. I think use it once a day for a couple of weeks. By that time, your skin should be virtually getting back to normal. You then taper it down. And I talk about weekend therapy, where you perhaps put this on Saturday night and Sunday night, but any 2 consecutive nights a week for another few weeks. I generally prefer to drop the frequency rather than dropping the strength, to try and keep things as simple as possible and get away with just one prescription. So if my patient comes see with a flare, well, the first thing I'm talking to them about is avoiding detergents and going into some detail. Sometimes it takes me 20 minutes to cover that in detail. And to use an emollient to wash with, to use an emollient when they get out of the water, and to share with them which emollient they're going to use and how much they're going to use, and not putting their fingers into the tub to contaminate it. And having a good pump dispenser that recharges and delivers the right amount and empties the container completely. So the quantities, and there's a lot about choice of emollients, but that's not what I'm here today to do. Then initially I'll start a topical corticosteroid just once a day at night, perhaps do that for a fortnight, and then drop down to weekend therapy. But the view that I stop ideally by about week 3 to 4 and certainly beyond. But I'll be starting that topical immune modulator at the same time. Now, normally those are used twice a day. That's the normal dose for them. But because they can cause a bit of stinging when the skin's inflamed, when you first start to use them, I often put this on just once a day, that's in the morning. The stinging, if it does happen, only lasts for a few minutes and stops once the skin's no longer inflamed. And then usually by about week 3, after a fortnight, they can drop that down to, increase that up to twice a day, actually the normal dose, as they're dropping the steroid down to weekend therapy. And there's 2 nights, Saturday night and Sunday night, when they're using the steroid, they just leave off the topical immune modulator. And then we go down to maintenance dose, which is where they put the topical immune modulator on just twice a week. And they can do that for months and months on end at that very, very low frequency. And that will keep their eczema at bay, rather than coming back all the time and seeing the doctor and having flares and not working and all the problems that eczema brings. Eczema controlled. And no antibiotics. I hate antibiotics. Yes, if someone's ill, well, they need to be in hospital. But we use antibiotics far too much. And people have shown that using antibiotics for treating eczema in primary care and general practice makes no difference unless the patient is ill. We shouldn't be using antibiotics. They knock out your healthy microbiome. They increase the chance of getting resistant bugs, and they increase your chance of getting an allergic reaction to what was previously a very good antibiotic for you. So when you really need it, you no longer can have it. So we should keep away from antibiotics. But if we can prevent the flares, then the need is gone. I just put that in. If you want to be empowered, I would suggest you just download this. You can get it on the internet. Just put poem eczema into your search engine. Download it. it's a patient-oriented eczema measure, and it's a way of marking how severe your eczema is. So you can do that. It's how bad it's been over the last week. Were you to contact your doctor and say, look, my eczema is really making my life miserable, and by the way, my POEM score is 17, they will need to know that they've got to take that seriously. So if you can complete that and share it, it gives a much more objective measure of how much your eczema is really distressing and disturbing you at the moment. So those are my slides. I think that's all I had to say. Yep, I'll stop sharing. I hope you didn't mind me using quite so much in the way of slides. I'm absolutely not saying don't use steroids, as you can see. I absolutely am, but they're designed for short-term use. And if you have a flare of eczema, then you need to think, what am I going to do to prevent that coming back? Using antibiotics won't help. Steroids aren't a great idea longer term. You've got to think about how you're washing, how you're looking after your skin, how much emollient you're using, which emollient you're using, where you're using it, and looking at those things as far as possible. Yes, there's so much else to cover in eczema, but I've just covered some of the therapies, but predominantly management of eczema is avoiding detergents, using emollients, short courses of effective topical steroids to break that flare, but then into flare prevention, lifestyle, and everything else. And I think at that point I should probably shut up and listen to some comments or questions.
There's a lot of questions which I'll start reading in a moment, but that was just so interesting, and I really felt that you took us all the way on the sort of journey, and a lot of practical things that I would ask, and very interesting to hear, sort of how a mother, suddenly gets a problem themselves, even though she thinks she's washed her hands properly.
Yeah. Oh yeah.
I have to ask, you say that you always wash your hands, and then with the normal thing, and then you use the other thing to get rid of whatever it is. Is that because you suffer from eczema, or is it because you're just aware of the damage detergents can do, full stop?
I don't have eczema. I'm very, very lucky. No, simply because I'm aware. As you get older, your grease production goes down. The skin of a 70-year-old, and I hasten to add I'm not 70, but the skin of a 70-year-old is half as thick as a 17-year-old, the epidermis. So, and your sweat production goes down. So your skin, the barrage of detergents that your skin would tolerate when you're a teenager with greasy, sweaty skin, that same amount of detergent when you get to your 60s, 70s or beyond would be devastating. I see a lot of eczema in older people, dry skin, which is then itchy, and they have horrible problems with dry, itchy skin. So no, I wash with, I was famous for saying that soap is a 4-letter word. And I'm the dirty doc who hasn't washed for 20 years with soap. I wash every day. I wash with an emollient. I just hadn't put any soap, detergent, shower gel, or shampoo anywhere near. I'm lucky I haven't got any hair, so I don't need to use shampoo. I just put a bit of conditioner on once a week or so. And my wife says, she doesn't complain about smell, and she's got a good sense of smell. She hasn't had COVID yet. But since COVID, yes, I do now wash my hands with soap rather than just with an emollient, but I also then wash them with an emollient. Once I've killed the virus, I then look after my skin.
And I think people are very aware now of, of hearing about everybody with their red raw hands. They now understand. It's becoming more, people are aware.
A study from Sweden showed that only 1 in 5 doctors is doing anything to look after their hands, and yet some of them washing their hands 70 times a day.
Amazing, isn't it?
And only 1 in 5 is doing anything, or 18% in fact, is doing anything like what I'm suggesting. So no wonder they're having bad problems.
Yeah, so we do have a lot of questions, and it's going to go up to 20, I think, in a minute. So I'll need to try and rattle through them, although I suspect that some of them you may have actually answered already through your chat. But one of the things is, and I like the way that, so that we, you suddenly find that you've got severe eczema, you go, the doctor gives you the straightforward, try this steroid. Hopefully he explains to you, it is only a certain time you should be using it, and then possibly come back for review after that sort of 3-week period. If you then find you go into a flare up, and the doctor says, okay, we'll just go back to using the steroid again, what would you suggest is the best way to ask the doctor to say, well, would the doctor even think about offering you, is it a modulator?
Topical immune modulator. Thank
Yeah.
you so much for raising that point. I think, unfortunately, the vast majority of GPs, I lecture to GPs 3 to 4 hours a week nowadays, doing webinars, including on eczema. And I'm talking to audiences of up to 200 or 300 or more. And it's patently obvious to me that they're not familiar with the topical immune modulators. They're not comfortable with them on the whole. I mean, there are some, but the vast majority of doctors are not in primary care, in general practice. And many of them have been advised that they shouldn't be prescribing them by their CCG. Their formularies prevent them to some extent from trying to prescribe them, and they're being told that they can only be prescribed by specialists or GPs who have a special interest who are being employed in that role. That's rubbish. Absolute rubbish. They are in the British National Formulary. Doctors can prescribe them. They're not familiar with them, and doctors don't like doing things they're not familiar with. They've had some bad press, which has been totally undeserved over the 20 years. When they first came out, because one of them, tacrolimus, is used in a very high dose by injection for patients with renal failure and transplants and things like that and other conditions. In those very, very high doses, used what's called systemically, now not topically on the skin, can be associated with lymphoma. And so also doctors were worried it might cause this solid leukemia, a lymphoma. But actually the evidence has shown that that's no more likely than eczema causing lymphoma, no more likely than topical steroids causing lymphoma. It does happen, but it's astonishingly rare. A few cases in the world literature. And so we're now pretty certain that these are not a worry. That's not a worry. And they're much bigger molecules. They're over 500 kilodaltons. Tacrolimus, I think, is around 600, and pimecrolimus is more like 700, whereas topical steroids are all less than 500 kilodaltons. And that's the threshold for getting through the skin. So they're barely absorbed, if at all.
Right. Okay.
But doctors, no, you're absolutely right. Doctors are not familiar with them. They don't like to prescribe them. And finally, NICE in 2004 didn't feel that they were cost effective. The National Institute of Clinical Excellence, which I sometimes call the National Institute of Cost Effectiveness, decided that because they cost more like £30 per tube rather than a tube of steroid, which is £1 or £2 on the whole, we can't justify everybody with eczema using them. But actually, when you put into that equation the cost of going to hospital, or the cost of not having a night's sleep, or the cost of having uncontrolled eczema, and the cost of doctor time and everything else, the costs of uncontrolled eczema are manifoldly greater than the small additional cost of this treatment. I think we could really make a change if we use these drugs that really work. And yes, it's an awful lot more expensive to buy the tube, but then after 2 to 3 weeks, you can then drop down to this trivial maintenance dose and have no more flares. That's been the experience of my patients. You stop the flares.
Okay, right, we're going to, oh my God, questions have just whizzed up, so we're going to have to do real quick answers here, George. So, do you know of any research that's been done to find out why some patients may become addicted or the steroids stop working?
No, I think that's a wonderful question, and it absolutely is needed. I'm not aware of any research. I do know that the BAD, the British Association of Dermatologists, is acknowledging that this is an issue. I think they've also acknowledged very recently that it is an under-recognized issue, and so under-recognized problem. And I think they'll be saying something about that in the foreseeable future. So I think they're onto it, and I think that's an area that definitely does need some research. The moment we're saying, I think, correct me if I'm wrong, I'm thinking that people say it only is a problem for 2 to 3% of individuals. But what it is about their skin that they get this rebound problem, exaggerated rebound problem, terribly uncomfortable red skin, I don't think we know. I think it's much more common than we currently acknowledge. And I think it's an area that definitely needs some research, but I'm not aware of any that's going on. Sorry.
Yeah. Okay. Well, I think we sort of half answered this. How do you suggest a patient who thinks they're addicted to topical steroids should approach their doctor or dermatologist if they don't understand or accept this might be happening?
Well, I think that they will be empowered, hopefully, in the very short term, when the BAD are producing a statement on this, along with the National Eczema Society. I think they're both going to be making a national statement about this in the very foreseeable future. And that will be then, you can go onto the BAD website, which is open to anyone, just bad.org.uk, I think it is. And if you just put in steroid withdrawal, it should take you to a statement from them. And I think if you could send that to your doctor, it's from the specialist in this field. That would empower you, I'm sure.
Yeah.
I think for those who are getting it, it's a real problem. As far as managing it's concerned, frankly, I think the only thing is to stay well clear of steroids. You may want to try tapering the dose down, but I think probably the best advice is to go cold turkey and have a few horrible weeks while your skin is really terrible, and then just keep well clear. But be aware that lots of treatments have steroids in them that it's not obvious. Dactacort or Canestin HC or Fusidin H. These are all creams that are regularly used that have a little bit of steroid in them, and you've got to be very careful there.
And why do you think some people have problems with steroids and some don't? No idea. I think that's what you said. No idea.
Yeah, no idea really. No, obviously the younger you are, the older you are, and the area of skin, the thinner the skin, the more vulnerable it is going to be.
And another question is, do the creams or ointments only thin the skin on the area they're applied, or can it affect other areas as well?
Interesting question. I suppose creams are more likely to spread around. An ointment tends to stay where you put it more easily. So a cream is more likely to move on to surrounding areas of skin. Yes, some of it is absorbed and will then go around the body. Whether it then goes around the body and concentrates back into the skin to cause thinning elsewhere, I tend to see the local effects of steroids locally where the steroids has been put. I think that more distant problems are likely to be due to contamination onto that area, but they're not that dangerous. I mean, please don't take away from this remotely that I'm saying don't use steroids. Then they are wonderful drugs, and I use them. And as I said right at the beginning, I could not imagine practicing without using them. I'm regularly recommending them, but I'm desperately keen to get off them as soon as I can for the reasons I've explained.
Another person who has used cortisone ointment, which did work, but it has left the area that she used it on very thin, and especially around her eyes, and it's split and it gets sore. And she doesn't know. Can you advise what she can use to help that?
Yeah. And if you're using something that's working, that's great. When you get eczema on the eyelids in an adult, I have a very low threshold for being concerned there's some contact allergen that's driving that. There could be a contact allergic or a contact irritant problem. So I have to say, I've seen eyelid eczema from nail varnish. You'd have thought you're painting the nail varnish on the fingernails, but actually it dries, and then you just touch your eyelid to scratch your face or whatever, and that tiny exposure to this the skin on the back of the hand is quite thick and actually resistant to contact dermatitis there. But the trivial amount that gets from that nail lacquer onto your eyelid can cause a contact dermatitis, or it could be one in the air, an atmospheric allergen. I've seen it from fragrances. A girl who had terrible facial eczema, particularly on the eyelids, due to her boyfriend's spray, for his antiperspirant spray. If she went through that mist, or hair dyes or hair shampoo. So if you're getting eyelid eczema, I'm thinking about particularly something called methyl-acetylzolinone, MI, which is present in so many products, hygiene products like shampoos and face wipes and creams and things that people use, sunblocks. And it's not an uncommon driver for this.
Right.
But the eyelids are very, very delicate and vulnerable. It's an area where I try to, you may be getting a I said perioral dermatitis, but the proper name is periorificial because it occurs around the eyes as well as around the mouth. And it may be that you're getting a steroid-driven dermatitis due to the steroids, not an allergy, but just a reaction to the steroids causing this. Settled down by steroid, but then created and made worse by the steroid. And I have to say again, I find Protopic or Elidel, these topical immune modulators, are usually fantastic for that. So I'd be much more keen to go for a topical immune modulator there, and because they're designed for thin skin, they don't thin the skin. They reverse. I forgot to say they reverse that thinning you see in the stratum corneum when you've lost those 15 layers. They reverse it, so they regranulate the skin. They reverse that thinning. They don't cause any thinning of the skin at all. They reverse steroid thinning.
We have a lady who's a professional homeopath, and she was just saying thank you, and how good it is to stress, because she says that GPs don't, is how to come off steroids, slowly, how to do it to reduce it. Just saying, how important that
And
is.
there are some conditions, nasty inflammatory conditions. I'm not talking about eczema particularly, but things like lupus on the skin or lichen planus. These are chronic, difficult inflammatory conditions for which we've got very few alternatives. And these individuals need to use potent topical steroids and need to use them sometimes for a very long time. And that's the right treatment. I would endorse that. But in eczema, we happen to have this wonderful group of other drugs that are really effective. And I think we don't spend enough time with our patients talking to them about how they wash and how they should be washing and how they should be using their emollients. Emollients are absolutely the answer.
Yeah, I mean, we work with a number of people that manufacture them, and a lot of the emollients, it's very hard to research, which ones do you recommend. I mean, there are so many that are very good out there, but like we certainly know with our anecdotal trials that they're only as good as how well you use them.
Yes.
And it's really,
and that depends on using one that you like, and I think it's terribly important your doctor gives you the one that you say you like and will use. Absolutely.
Yeah, yes. It's really and this is a really good question. So do you recommend people to reduce protopic wean off, and what happens if you stop using protopic? So I suppose if you've now managed to get your doctor to prescribe you protopic or the alternative, how do you then start coming off that? Because obviously you don't want to be on that all the time either.
Well, it seems to be perfectly safe used long term, but generally speaking, I think using it twice a day, you will have got 90+% of the benefit, in my experience, after 3 to 4 weeks. And so at that point, I say you can taper it down. So we'll just drop straight down from using it twice a day to dropping it down to twice a week. But keep going like that for several months, at least. And any hint of a flare, the moment you feel your skin suddenly getting out of control again, think about what's driven that. Has it been, have you left some shampoo on the skin? Have you used a detergent too much or whatever? Have you not been using enough emollient? Or is it because the weather's drier and the central heating's on, or you've got air conditioning on, or whatever else is aggravating it? But then immediately step up back to twice a day for a couple of weeks, 2-3 weeks.
Okay.
But I've got many patients who've had devastating eczema, and we've been thinking about whether to go on to second-line agents like nasty toxic drugs or phototherapy or whatever. And Protopic has managed to change their lives, and they've just used a maintenance dose for 6 to 7 months or longer and not had a flare at all.
Wow.
And they've adjusted their lifestyle.
Now this is both of those are prescription only drugs, are they?
Protopics are, yes, the topical immune modulators and the topical corticosteroids. You can get the 0.5% hydrocortisone over the counter, but you're not supposed to use that on the face when you buy it over the counter.
Right, okay.
Plus 9%, 0.5% hydrocortisone cream is probably about as strong as the cream base.
This is a good question. Is topical steroid withdrawal a real thing? Now, yes. I know the person who's written that, and she will say yes.
Yes, no shadow of doubt. It doesn't affect every single person who uses steroids, but no, it is not. You might ask me, do I believe in fairies? It's not. No, it is absolutely a real thing. Those individuals, that their lives can be completely destroyed by it. But it doesn't affect everybody, and we don't really understand it. Yeah. It's funny how the medical profession can blinker itself to things we don't understand, isn't it?
We're going to have to draw this to an end because I've just realised we're going on, and I've got loads more questions here. But this is what, would this approach be suitable? And I presume he's talking about the sort of the modulator approach, be suitable for the type of eczema which is fissured skin rather than itchy fingertips.
Yes. So fissured just means splits in the skin, cracked. So you're talking much more of a sort of dry, less itchy skin. It may be that the individual who's saying this has got a condition where they're not making proper filaggrin. There's a condition called ichthyosis, which is rather rude of doctors to call it that, because ichthyosis means fish-like. Vulgaris, which basically just means common. And ichthyosis vulgaris affects probably 2 to 3% of the population. Very, very common. And they have what's called a loss of function gene mutation. The gene that is controlling their production of filaggrin isn't properly working. So they make faulty or absent filaggrin. And without the filaggrin, they run into all sorts of problems. 50% of patients with eczema atopic eczema have got a loss of function gene mutation. So it's not 100%. And many individuals who've got a loss of function filaggrin gene mutation don't get eczema. So it's interesting. But if you've got non-itchy, dry, fissured skin, I suspect you've probably got ichthyosis vulgaris, which is very, very common. And it just means that you're very much more vulnerable to the damaging effects of our modern lifestyle. Our ancestors didn't live in modern dry houses with dry walls, dry carpets, central heating and air conditioning, and they just, and washing every day. The skin was never designed to cope with today's barrage of environmental things that aggravate it. And so your ancestors would have coped with their ichthyosis vulgaris no problem, but today's world is not possible.
Right, and I think with that, we will draw this session to an end. What I will do, though, is, and we've had obviously a few people leaving, is I will send this out to everybody that was on the signed up for the webinar. Talk Eczema, Talks Health, is very much about educating people so that they can understand, and then they have a choice to decide how they may move forward with their treatment, how they may talk to their HCP, their GP, etc. So, and I think you've given people some invaluable information to arm themselves basically with how to go move forward with their treatments. So I'd just like to say thank you so much for your time, George. You've been great.
Thank you very much indeed, Katriana. Lovely. I hope it was useful.
Bye.
Bye-bye.